I'm Keith Kincaid. I'm one of the vascular fellows. Fellow is essentially a physician who's doing advanced training in a specific field. So we're doing vascular training, Alex and I. We'll be at Shands for about a year, completing that training, seeing stroke patients and delivering best care that we can. How many people have had their lives personally affected by stroke? And by show of hands. That's a number of individuals in this room, absolutely. So stroke remains, one of the most popular diseases for people to have in America. I think it's continually gone down in prevalence as we've made strides in the field. But interestingly, stroke is one of those diseases that it just has such a wide variety of presentation. Oftentimes, people don't know what's going on. And we've gotten to the point, and we'll talk about what we can do for stroke, but we've gotten to the point in the field where the provider's knowledge is not enough. I can know everything there is to know about stroke and how to treat it and how to prevent it and how to, make all the symptoms even go away in some businesses, but that's not enough. We're at the point now where it also depends a lot upon the patient. The patient needs to know what's going on. Because if the patient doesn't know what's going on, they may not show up in a hospital setting, they may not show up in a healthcare setting until far beyond the window that we can help them. So things like this, where we host these events, is really it's a really important endeavor to educate potential patients, potential individuals who may have strokes, to recognize the symptoms so that they can get the care that they deserve, really, and increase the opportunity of complete rehabilitation and getting the best outcomes. So I'll start by kind of walking through what is a stroke. We're going to just keep it very basic today, okay? So you may not have known this, probably not, but the etymology of the word, I'm a fan of etymology, and I like to know where words came from. A stroke actually originated in Old English, and very straightforward. It's a blow or an act of dealing a blow with a weapon, but when it came to when a patient has a stroke, is actually abbreviation of the phrase, the stroke of God's hand. People didn't know when patients would have sudden decreased consciousness. They assumed that they must have had some brush with the supernatural, and that's often how we typically explain things before we really understood the science behind it. But we still call it stroke today. It's just something very catchy. I think everyone recognizes what that means as a general principle, but to better define it, to clarify, it's essentially a neurological deficit attributed to an acute focal injury in the brain or the spinal cord due to vascular causes. There's a lot of different things that can happen to the brain, but when we talk about stroke, we're just talking about the circulatory system and how that can interrupt brain functions. So it's important to recognize still that there's a couple different types of stroke. The two main types are when we have an occlusion of a blood vessel, which deprives a certain specific part of the brain from oxygen. And the other type is when we have the rupture of a blood vessel, which causes bleeding in that area and also causes brain dysfunction and can also present with symptoms, but that also is a bit different, okay? Today, we're mostly going to talk about the type of stroke that is due to an occlusion of a blood vessel. And that's really what people think about when we're talking about stroke. And that, in essence, makes up the majority of strokes in America. 75 to 85% of patients with stroke will be because of an occlusion of a blood vessel. And the brain injury from that occlusion occurs because of a lack of oxygen. So it's actually very straightforward illness. If you occlude the blood vessel, if you say you're sleeping on your leg wrong, or you're sleeping on your arm wrong, you raise your arm above your head, it starts to feel numb and tingly, right? That's because you're not getting blood flow to that part of the body. And this is essentially the same exact process, only a more irreversible type of process where the blood clot actually is preventing blood flow. And you can't just change your position to restore that. You need to go after that and break it up or pull it out. And then we're going to talk about that today. But the key thing about stroke, and I think that I really want to emphasize, at least my part of the talk, is that depending on the blood vessel that is occluded, the way that it presents is very, very different. And this is what I think challenges most patients when they're having a stroke is what is going on. I'm familiar with a bit of what a stroke looks like. My family member had a stroke, but this is different. This doesn't feel like a stroke. Maybe I'll just see if it goes away. And oftentimes it may still be a stroke. We just haven't educated the patient to know what that looks like. So let's do that, okay? So let's first understand the brain. It's not like any other organ in the body, okay? It's depending on where you're talking about in the brain, widely different processes and functions and potential symptoms. If you have a heart attack, it's from a blood clot in the blood vessel of the heart. Whether it's in the anterior portion of the heart, the posterior portion of the heart, you're having a heart attack. It's going to be pain that you've never experienced before, and you're a healthcare provider. But when it comes to stroke, you may have a blood clot and it may just make you have a little bit of blurry vision in one area. It may have you forget how to say some things. It may have you stumbling over your words or not able to pronounce words correctly. It may give you a slight imbalance or a dizziness that you haven't really had before. And those aren't immediately alarming things, especially when they're small. But that doesn't mean that we can't potentially do something about that, okay? So there was one initiative back in 1998, actually in England, and this was the FAST. I don't know how many, show of hands, who's familiar with the FAST initiative for stroke recognition? Just kind of like, oh yeah, so I think it's fairly widely known, even amongst non-medical experts. But this was actually an endeavor in England to enhance the recognition of stroke among healthcare providers, not even necessarily the public. And the goal was to get healthcare providers to recognize these symptoms in the field so that we can do something about it immediately. But again, that does depend on the patient calling 911 and seeking out that healthcare attention. So when we talk about the symptoms, right, FAST really identified a few of the main ones, one of the most common ones, right? F for anybody, what was the F stand for in FAST? Face, exactly. And when we talk about face, really it's specifically facial weakness or facial drooping. Now there's several different reasons why someone's face might be drooping, but for it to start acutely, meaning it was not like this yesterday, it was not like this when I went to bed, but now I'm waking up, I'm looking in the mirror, and suddenly, my face looks a little bit asymmetric. It looks a little bit crooked, especially in the lower mouth. That's going to be the part that's really of concern. So that was one of the symptoms that we noticed. Okay, we wanted people to be aware of. We lost light. Oh, there we go. Oh, okay. We're just keeping it a little dramatic in here. Okay. The A, what was the A standing for in the original FAST? Arm, right, yes, arm weakness. And I would go so far as to say also probably arm numbness, right? It's not when, it's not the same thing as when you, like I mentioned before, you raise your arm up high and you're kind of losing perfusion, you get that numbness and tingling. You have that tingling, but it doesn't go away when you move your arm down. You have weakness in your arm that makes it unusable. And suddenly you feel the urge to grab your arm and kind of cater it around like this. That's a very natural response. If you're doing that, something's wrong with your arm and you need to call 911, okay? You could be having What we did for stroke 40 years ago is like, I would say it's almost like ancient compared to what we do now. It's unthought of. And I'm not even sure 40 years ago whether it was imaginable what we can do for stroke now. If someone has one of these symptoms, presents within the time frame to be eligible for one of our procedures to remove that blood clot, I'm telling you, complete resolution of the symptom. We can stop it entirely, okay? No more stroke, right? But it depends on getting to that healthcare provider within a certain time, because if you deprive the brain of oxygen for long enough, irreversible damage can occur. And I'm gonna, I think this thing is kind of blocking the window. We can, maybe I can close this. Should I close it? That one? Oh.
Well, I'm trying to get back on the Wi-Fi.
Oh.
Apologize. I was told this wouldn't be a problem.
Well, while she's working on that, I probably don't need a microphone. I think I'm probably going to project my voice loud enough. But while she's working on that, we talked about facial drooping, we talked about numbness, we talked about problems with speech. Does anybody else have any idea of what might represent a stroke? What kind of symptoms, aside from the ones that we already mentioned? Wait, what was that? Balance. Yes, absolutely. Balance. And believe it or not, it is possible to have a stroke that just affects your balance. Say you wake up in the morning, you're not having any weakness per se, you're not having any numbness or tingling, but you can't walk a straight line. You feel as though you're a little bit drunk. Okay, there are parts of the brain that balance our movements. And so the original facts that helped us recognize strokes of when they affect large parts of the brain, the left or the right side, but not so much the posterior parts of the brain, okay? And balance will be a manifestation of a stroke that affects the posterior part of the brain. You wake up in the morning and you suddenly can't walk, that's a problem, right? That's a problem, especially if you're walking differently than you did yesterday and you don't know why, okay? What about vision? What about vision, right? We didn't really talk about vision in the original fact, but vision is one of the crucial functions that we take for granted on a daily basis. But imagine waking up and you no longer can see out of your right or left eye. That could be a stroke. That could be a stroke. And I think one of the most disappointing things, at least in our field, is that we so rarely see patients come in within a window to treat them when they have vision loss. Because it's odd enough, you know, we kind of always hedge with vision, don't we? There's always some weird thing going on with our vision. Maybe it's a little bit blurry for some reason. Maybe it's, you're seeing spots a little bit. And we always hope, well, maybe it'll get better in the rest of the day. You know, we always kind of do that. We kind of like tell ourselves, rationalize things. But I'm here to tell you there's two types of stroke that affect vision. One affects your vision on one side of the body. So no longer you're looking down in the middle of the room and I can see this side of the room perfectly well, but this side of the room, it just, I don't see you guys. You know, that's one type of stroke. The other type of stroke is when the blood clot goes directly to the eye. And that's when you lose complete vision in one eye. So you close that eye, you can see everything really well, but when you close the healthy eye, you can't see anything at all. And that's an emergency. Okay, that's a blood clot that goes straight to the eye, and we can't help you with that. If we see you in the right amount of time, we got to get you in as soon as possible. Vision loss is serious, and we don't see enough people with that. One of my hopes is that we get to, yes, ma'am.
Question. A couple of months ago, my husband had a big war of blood stroke. How is that different than this?
So when you say blood stroke, I'm imagining like a bleeding type of hemorrhagic stroke. So when we talk about, yeah, he was bleeding. So that's what we call a hemorrhagic stroke. And that was what I mentioned earlier. I'll get to you, sir, one second. What I mentioned earlier, it makes up a smaller part of strokes, but it can present with similar symptoms. Now, key part of hemorrhagic strokes is a headache. Oftentimes that will be accompanied by a headache.
Yeah, we just got it back up.
Additionally, you might notice that that person's not quite as alert as they normally are. They can still present the same types of symptoms because it's affecting the brain. What I mostly want to get across is if you're having those new acute symptoms of neurologic function, you're no longer able to function as you used to, and that's new for you, that could be a stroke, whether it's from a blood clot or from a bleed. They can both produce the same symptoms. There's a lot of overlap and a lot of gray area. Oftentimes the bleed is because, oh, got that all set? Yeah, I'll use the mic now, thank you. Oftentimes there's a lot of overlap and a lot of gray area, okay? I mentioned headache. Not everybody with a bleeding stroke is gonna have a headache. Sometimes people with a blood clot will have a headache, you know, so it's not always black and white. There's a lot of gray area, which is why it's so important that if anything comes up, you should seek medical attention immediately, as soon as possible. Yes, sir.
Talking about time being of the essence. Are we talking about minutes, hours, days, months? What's too late?
Yeah, and we're gonna dive into that with Dr. Senator, but I will tell you it's generally a matter of hours. Generally a matter of hours. You know, we are constantly expanding the window of therapeutic options. And there's a lot of research that we put into trying to figure out what's the limit. How far can we go with these therapeutic options until we're starting to no longer be a benefit? Right now, as Dr. Alex will, you know, Dr. Senator will kind of cover, right now the window is about 4.5 hours from the symptom onset. So as soon as the symptom starts, if you're able to recognize when the symptom starts, 4.5 hours from then, that's generally the therapeutic window. Now, if we're talking about a blood clot, a hard clot that we can potentially remove, sometimes we can expand the window up to 24 hours, okay? But it's always kind of a risks and benefits sort of perspective, right? We depend on a lot of our imaging studies that have come a long way to recognize how long has that brain gone without oxygen? How long has it been since those symptoms have been present? What's the risk of, if we pull that blood clot out, that they might bleed in that area as a complication of the procedure? So right now, I will say it's a matter of hours, and the earlier, the better. Just as a general rule, the earlier, the better. Oh. We're back. Okay, let me,
The Wi-Fi went out.
oh, okay, yeah, it's still not letting me navigate though.
With the clicker?
Oh, there we go. Okay, so as far as the stroke symptoms, I think we covered a lot of things. I don't want to overwhelm everybody, so I'm going to leave it there. There are some other mnemonics that I think I wanted to just mention that sort of encapsulate more of the stroke symptoms that we're now recognizing are treatable conditions, specifically the vision loss. I really want to emphasize that we almost never see patients come in within the window for help when they have vision loss. And I would love to be able to see a change in that perspective. When you have vision loss, seek help, because that's one of the symptoms. Once that damage is done for vision, it's extremely hard to rehabilitate, and oftentimes it does produce disability. And we're talking about driving. We're talking about not being able to drive anymore, not being able to operate a motor vehicle. This is a very, you know, we don't recognize the consequences of not being able to see properly. And if that person were to present within a window for help, we could potentially save that vision, but we don't see it enough. So I just wanted to emphasize that it's not typically thought of, but that was kind of the emphasis that I wanted to make. I'm going to introduce Dr. Alex Senator. Again, he's one of the stroke fellows, works alongside me, and he's going to talk about the treatment options. As you were asking the question, he's going to go over a lot of those details.
Hello, everyone. I hope everyone's having a great World Stroke Day. Like Dr. Kincaid said, my name is Dr. Senator. I'm also one of the stroke fellows here. And I know that a lot of people have questions about what's going on, about different things that may pertain to their lives or others. And we're going to answer a lot of these questions at the end. We've built in time for these questions. But I wanted to specifically focus on treatment of stroke and why we care about the timing of stroke. There's two main types of time-sensitive treatments and why we tell people to come to the hospital so quickly. One of these is a medication called TPA. It's a clot-busting medication. And the other one is a neurosurgical procedure. This is called a mechanical thrombectomy, but it's an emergent procedure where they try to pull the clot out. And these interventions are dependent on several factors. If the clot is very big, how quickly the patient comes to the hospital. This isn't for everyone. It depends on each type of stroke. In particular with TPA, it's a strong clot-busting IV medication. There are different other types, and I'm going to gloss over some of the details and you can look on later front the slides. But the important part, as mentioned before, is that if you're in the hospital very quickly, within 4.5 hours, that you're able to receive this treatment. So a high majority of the patients who receive this will receive good benefit or minimal improvement. However, this is a high-risk medication. There is a risk of bleeding with this. And because of that, we don't want to give it to people who are already at high risk of bleeding. Because it's such a high risk, especially in bleeding in the brain, that we actually monitor people in the ICU for at least 24 hours to make sure that they don't have a complication related to this medication. And that's why we check to see, are people on what's known as a blood thinner, which is warfarin or Eliquis, if they had a history of brain bleeds, or if they had other major trauma or surgeries that yet again will put them at a higher risk for these type of injury. So mechanical thrombectomy is the next exciting topic. And this is an emergent procedure, as mentioned before, and where we take a wire and pull the clot out from the brain. There's actually a wonderful model in the back that for all of you to play around with. It shows different types of wires and guides that can pull out these clots. And even if you don't make it within that 4.5 hour for TPA, it's still within 24 hours, a full day after a stroke occurs, that you can still have this intervention. However, as of stroke, the sooner the better. As the stroke progresses, the lack of blood flow to that area of the brain will cause a dead tissue that's called core. We can't fix the core, but we can fix the area that's still at risk, the area that's still alive, that's not getting enough blood flow there. And yet again, all these procedures are very emergent, and yet again, we'll need ICU monitoring for after this event. So here's a little diagram kind of showing the wire going up to, usually going to be the internal carotid, but one of the arteries of the neck, and trying to pull the clot out here. And there's different types of devices. For instance, this one is called a penumbra suction aspiration device. It's a clot disruption where a separator is threaded through and pieces are broken loose, and it tries to suck all those clots back in. Another one is called a solitaire or Trevo device. This acts like a stent, where that's the one in the model in the back, where it opens up and it slowly adheres the stent to the clot. And then after a few minutes, you're able to pull everything back out. Here is another unique model showing this type of device in terms of how it looks in the brain. And here are wonderful pictures showing exactly how much blood flow comes back to the brain after this type of event. You can see the before side on the right showing that black area is all the blood vessels and all the blood that's going to a brain that has a stroke. And on the right-hand side, the afterwards, you can see how much more blood flow is going to the brain, how much brain that we've saved because of pulling this clot out. So I think it was mentioned before, what if you're too late? What if it's 2 or 3 days out and you realize you have a stroke? Some strokes present with neglect, meaning that you don't recognize that you have these issues. It's still important to come to the hospital, get a proper evaluation, because you can have more strokes. You can have various complications. We need to adjust and identify why you had your stroke and be able to treat the risk factors for it. This usually will require hospital monitoring, but not always. And it usually requires close treatment of somebody's blood pressure, treating other conditions like dehydration, diabetes, poor cholesterol, and then checking their swallowing, their speaking, and checking for other rehab potentials of stroke. And I want to briefly touch on different medications of stroke too. So next is prevention. And to break it down into 2 broad categories, there are antiplatelet medications. These are like aspirin, Plavix, Brilinta. And then there are your typical blood thinners. So when somebody says they're on a blood thinner, I assume that it's something like warfarin, Eliquis, Pradaxa. And more specifically with the antiplatelets, these are used usually for smaller strokes, or if there's narrowed arteries in the brain, or if we don't have a clear etiology of it. And I should, before I move on, I should mention that the different treatments will all depend on what stroke that occurs. It's not that one medication is best for everyone. It will depend on what caused each stroke. So I think everyone knows about aspirin. This is a very common medication, and a daily aspirin is what's commonly used for stroke prevention afterwards. Plavix or clopidogrel is another common medication. Sometimes, again, depending on the stroke, we may use both of these medications together temporarily. Brilinta is also another common antiplatelet medication, and sometimes is used if Plavix is the best medication for somebody. Now for the blood thinners. Usually these are medications if somebody has an abnormal heartbeat known as atrial fibrillation, if they have a clot in their leg or their heart, or if they have very severe heart disease. Warfarin is probably one of the oldest medication, also known as Coumadin. It's usually cheaper, but you also have to have regular checks to make sure that the blood levels are thin enough to make sure you're not at high risk for these strokes. And there's all these new categories, and I don't expect you to memorize this. It's mostly to understand that there's multiple different types of blood thinners, with the most common one from the stroke world being Eliquis, also known as apixaban. But there are other types like Xarelto, enoxaparin, and heparin that are commonly used in the hospital, and it will depend, again, on what type of stroke that has occurred. There also is a type of surgery that if the blood vessels of your neck are extremely narrow and they have a lot of plaque, that sometimes you're able to remove the plaque from your carotid artery or put a stent there to open it back up. This will usually depend on different risk factors and for the patient, and depending on the surgeon preference. Here's a little example of how this would look in terms of the carotid surgery, removing that plaque and then trying to close up the artery afterwards. And I also want to emphasize, after a stroke, if you have weakness on one side, if you have trouble with fine movements of your hand, if you have trouble navigating because you have vision loss, that is why we care so much about trying to regain what was lost. And that's why we focus on multiple aspects of therapy. So there's physical therapy, which usually focus on the ability to move, occupational therapy, which improves the ability of daily living tasks, and speech therapy, which has 2 focuses. One is focusing on the speech output itself, and the other one focusing on swallowing. Usually each of these are evaluated at the time when somebody has a stroke, but depending on how severe it is, may have longer term rehab needs. I think it's also common for people to ask what are different types of rehabs. And one of them is inpatient rehab. And that's when somebody needs to be physically at a rehab for possibly several days to weeks to longer to focus on very intensive rehab needs. There's home health care, which will yet again, those are people that come home to help you focus on these rehab aspects. And then there's outpatient rehab, where you can go to the rehab center, but you're still able to go home and still do your other activities. Now, one isn't necessarily better than the other. It yet again depends on what stroke you have. It depends on what type of difficulties that you have and what you're able to work on. So that will usually be determined by the physical therapist and the other therapists that see you in the hospital. Excellent. I'm going to leave it now to our wonderful director, Dr. Khanna, to finish this.
Good morning, everyone. So we gathered today. I'm Anna Khanna. I'm the medical director of the Comprehensive Stroke Center in our global enterprise, now University of Florida. I've been at UF for a while, almost 12 years now. But prior to that, I've been practicing and specializing in stroke for many, many years. So today we gather to celebrate and to recognize World Stroke Day, which is actually October 29th, but unfortunately it falls on a Saturday this year, and that's why we decided to recognize this day today. And the meaning of this day is for the entire world to come together to end stroke, for all of us to answer the question, life is why, and this is what we have to do, work together in order to end this terrible disease. So my focus of my talk is going to be on hemorrhagic stroke, or the bleeding type of stroke, because you've heard a lot about the clot type of stroke when there's blockage in the vessel. So the type of stroke I'm talking about when there's bleeding in the brain, when there's a rupture or explosion of a blood vessel, and then blood enters the brain. So it's the bleeding type of stroke, and that maybe is what you were referring to. So we call this hemorrhagic stroke. We don't talk about it as often as ischemic stroke because it is a less common stroke. So about 17% of all strokes are going to be representative of hemorrhagic stroke. We divide hemorrhagic stroke into two main categories. Here on your left is intracerebral hemorrhage, where you see this kind of, not very good with this pointer here. Let me see if I can do better here. You see this kind of white stuff within the brain. That's blood in the brain, inside the brain tissue. This is called intracerebral hemorrhage. And here on the other side is something called a subarachnoid hemorrhage, where there's blood in the spaces inside the brain. We call this the subarachnoid space. It almost looks like a spider inside the brain. These two strokes have very different mechanisms and causes, which we're going to talk about. However, the majority of our hemorrhagic strokes are going to be representative of intracerebral hemorrhage. Okay. So although it is a less common form of stroke, we still see it very frequently. So 17 million strokes worldwide are hemorrhagic strokes. Intracerebral hemorrhage accounts for over 10% of all strokes worldwide, which translates to a 1.7 million cases worldwide of intracerebral hemorrhages per year, which is a lot of people. Although it is a less common stroke, it is the worst stroke to have in two ways. More people die from an intracerebral hemorrhage, and more people are left disabled from an intracerebral hemorrhage. So your rate of, we call it mortality, or your rate of death from having a bleeding type of stroke is over 40%. So 40% chance you're going to die when you have bleeding type of stroke. And only 66%, or most of the people are actually living with disabilities when they have an intracerebral hemorrhage. So if you count all of the people with an intracerebral hemorrhage, only about 20% are going to be independent. The rest are going to have some sort of a disability. And the other problem with intracerebral hemorrhage is, as of now, there's no specifically and scientifically proven treatment options for hemorrhagic stroke as they are for the blockage or the ischemic strokes, as mentioned by the other doctors, with all of these clot retrievals and the TPA and clot busters. Right now, we don't have a lot to offer for hemorrhagic strokes. So what are the causes? Well, by far, the most common cause of intracerebral hemorrhage is going to be hypertension. In fact, 70 to 80% of patients that have intracerebral hemorrhage have hypertension that cause the bleeding. There's other more rare causes. There's something called amyloid angiopathy, which is like a special protein that deposits into blood vessels, which makes them a little bit more fragile and rupture. Other things can cause bleeding in the brain is blood thinners. So although blood thinners are very, very beneficial, especially if you have had the other type of stroke, the clot stroke, and you have atrial fibrillation, or you may have a valve, a mechanical valve, then you need to be on blood thinners. However, the side effect of blood thinners in rare cases can cause bleeding inside the brain. Other things, aneurysms, and we're going to be talking a little bit more about that. Aneurysms and something called vascular malformation or arterial venous malformations. When all of these arteries kind of form like a ball of worms, they're really abnormal arteries, then those can bleed in the brain. And that we most of the time see in younger people. Trauma, obviously trauma. So you fall down, you have a motor vehicle accident, you fall off your golf cart, those you can get bleeding in the brain. Neoplasm or brain tumors, there are certain brain tumors that can bleed inside the brain. Venous sinus thrombosis is when you actually get a clot in your vein and not the artery, and those can have bleeding in the brain as well. And then you can have something called hemorrhagic conversion of an ischemic stroke. So you have the blockage type of stroke, and then that stroke is so big that it develops bleeding into it. And that's also not super uncommon, but it's more rare. Also vasculitis, when you have inflammation in your blood vessels and they become fragile, that can cause bleeding. And drugs, especially things like cocaine and amphetamines, we see that in people that use IV drugs, and they can have bleeds inside the brain. But out of all of these things, by far the most common reason to have an intracerebral hemorrhage is going to be hypertension. So what is the normal blood pressure? Normal blood pressure is 120/80 or even less in some cases. Did you know that 1 in 3 Americans have high blood pressure? And guess what? They don't even know it. Did you know that 80% of strokes could be prevented by having a very tight blood pressure and tight diabetes control and tight cholesterol control? And did you know that if you're in your 50s and you do not have high blood pressure, your lifespan is going to be at least 5 years longer? So we are all here together to recognize World Stroke Day and make sure that we have our blood pressure checked. We follow closely for our cholesterol and diabetes. We have an exercise program and we eat healthy. And this is what we're gathering today for, to prevent stroke and not to worry about the treatment. We want to prevent it. The other problem with intracerebral hemorrhage is expansion. So this is somebody that comes in and you can see all of this kind of white stuff here in the brain here. And this hemorrhage, this is an intracerebral hemorrhage. This is usually secondary to high blood pressure, is not so bad. However, these hemorrhages just by themselves, without us doing absolutely nothing, expand. And this is the same person within 24 hours, you could see how much more blood is in that brain. And that second scan is not compatible with survival. So that person would die. The expansion of your bleed most frequently occurs very, very early on. So within, if you could see that the biggest bar there, 0 to 3 hours, is the most likely expansion of the hemorrhage. As you go further out from your hemorrhage, the less likely it will expand. And in fact, if you're all the way out here, you present at 12 to 24 hours, you're only about 6% chance that it will expand. And after 24 hours, the hemorrhage is probably going to stay stable. So when you come in those beginning stages, that is the time to intervene very, very early on, because what you want to do is prevent that small hemorrhage from becoming a big hemorrhage and causing somebody to die or live with severe disabilities. So once again, you see the same pattern here, the same things that we worry about with ischemic stroke. We got to get that blood to the brain. We got to get that brain perfused. The same thing with the hemorrhages. We got to act quickly. We got to prevent that bleed from expanding where we can't do anything about it. And this may be a little bit difficult to understand, but size of the bleed really matters as far as rate of your death and as far as how well you're going to do and what your disability is going to do. So we characterize our hemorrhages based on, is it the size of a golf ball or is it the size of a ping pong ball? And if you look here, we say that a ping pong ball represents about 28 or so milliliters of blood in the brain. And a golf ball represents about 40 milliliters of blood in the brain. And if you look at this last bar graph here, mortality means death. The bigger the bleed, the higher your rate of death. So if you're in a ping pong ball, you're at 0 to 28, your rate of death is about 15%. However, as that blood is bigger, now you got a golf ball size bleed in the head, your mortality rate reaches 55%. And if it's even bigger, your mortality is 92%. So if that bleed is even a little bit bigger than a golf ball, 92% chance that you're going to probably die from this hemorrhage. So how do we prevent the blood from getting bigger, right? This is what we're here to discuss. Well, the main thing is we want to control blood pressure. So if somebody comes in and they have blood in the brain, we're very aggressive in the early stages, because remember, that's when the hematoma grows, get that blood pressure down. So we bring the blood pressure down really, really fast, and sometimes a little bit too fast. So we have somebody that comes in because they have blood in their brain because their blood pressure was high to begin with, and their blood pressure, say the top number is 220. We go so aggressive, we just drop it to less than 140 immediately. And that's actually the guidelines. We want to drop the pressure to prevent the explosion of the hematoma. The second thing we do is, obviously, if somebody's on a blood thinner, so if somebody's taking warfarin, somebody's taking Eliquis, somebody's taking Pradaxa, Xarelto, we have specific medications that we could administer that will reverse those drugs and get them out of your system. Because those drugs, if they're on board, then that blood is going to continue to expand. So if you're on those, we have medicines to get on board really, really quickly to reverse the process, make the blood more clotty again, and prevent the hematoma from expanding. The one thing that we're really not sure is, do we have any, if somebody is not on a blood thinner, is there any value of administering clotting type of medications to prevent the hematoma from expanding, in addition to the blood pressure control and all of that? And that is one of the things, and I don't know if you visited some of the tables back there, but this is one of the things that we're trying to study now. As a medical community, we realize we don't have a lot of treatments for hemorrhages. And if we have somebody that comes in, we treat their blood pressure, they're not on a blood thinner, can we give them a medication to kind of clot up their blood to prevent the blood from getting bigger? And this is a big trial that we're considering undertaking that you're going to be helping us today with. So the trial that we are going to be discussing, it's called FASTEST. And the reason it's called FASTEST is because we want this drug to get on board as quick as possible. Because remember, even if you give the drug too late, the blood is already so big that it's not going to help. So in this study, we're trying to administer this medication within 120 minutes or 2 hours from time of onset. However, we really want to be better than that. So we're trying to administer this medication in at least 50% of people within 90 minutes of time of onset. Time of onset is the first time you have neurological symptoms when you discover, something may be going on and something is wrong. But what you can imagine, if we're trying to get this drug in very, very quickly, and somebody presents to us and they're unconscious because they have bleeding in the brain, and we cannot find any kind of relative or friend to help us get consent, what do? So it's not fair to exclude somebody that we can't find a family member for. So we will want to give them a chance, and also be a chance to include it in the trial just as somebody else that can give consent because there's a family member next to them. And that makes this whole process very, very tricky, because if I'm going to take somebody off the street and I'm going to deliver a medication that has not yet been proven by the FDA to be beneficial without consent, what we need to get is from our community is consensus between all the community members to say, if that was me and I came to your hospital and I could not tell you that I wanted this drug or I didn't want the drug, I would still want to be treated. And we are kind of going on a huge campaign between your county here, our county, and Marion County, all the counties in between, asking the community, we're given the power to you to decide, would you want this particular trial in your community? And if you, as most of the people agree, then we could move forward to step 2 and onboard this clinical trial. But what we need to know from you, so if you be kind enough, and I'm not here to solicit for you to say yes. If you say no, I would not want to be treated without consent, I'm very much okay with that. But we have to get the majority to agree for us to move forward. So Relisa, wave your hand back there. So Relisa is taking, she has little surveys for everyone to fill out if you can, if you would be okay or not okay for us to bring this drug to the community. Anyway, it's called Factor 7, and we're going to move forward. So surgical treatments for intracerebral hemorrhage. There are so many, I don't want to gross you out after you just had breakfast, but there are so many really kind of crazy pictures out there. But most invasive surgery is when you go in and you open up the brain and you try to pull that clot out. And you could see how it's a little bit gross in that picture. We try not to do that kind of surgery for 2 reasons. One, it's number 1, very invasive. And number 2, you could imagine when you're opening up the brain, trying to get all that blood out, you in addition to getting the blood out, you're getting some normal brain in between. There's nerves, there's vessels, there's normal tissue in between. So it's very aggressive. And what we learned is that sometimes with these big hemorrhages, it's better either not to do anything than do this invasive surgery, because it causes more badness down the line and downstream than not doing anything at all, just keeping people with their blood pressure controlled and other medications, reversals and things like that. However, technology, right? This is where we are now. You know, as we advance forward, we have new technology that's actually can remove the hematoma in what we call in a minimally invasive way. And this is an endoscope. This particular one is called MECO. And what you do is you make a little hole in the skull, and through an endoscopy type of procedures, the doctors can look on the computer screen, and it's a small catheter that kind of goes in, and the examples of the catheter are kind of on top over there. There's different sizes. The catheter goes in like an endoscope, like you get an endoscopy, through a small hole in the skull, and can actually take out the hematoma. And this kind of technique is showing much more benefit, less invasive and less side effects as that major surgery when you open up the skull and get all of the blood out. So we're going to shift a little bit to subarachnoid hemorrhage. That is the second category of hemorrhagic stroke. Subarachnoid hemorrhage most of the time occurs either from trauma, motor vehicle accidents, golf cart accidents, blow to the head for whatever reason, or an aneurysm rupture. And this is kind of a representation of what little aneurysms look like. You can see they're like little balls inside the brain, off the blood vessels, usually at the branch points of blood vessels. And this is a little aneurysm there. You could kind of see it on the bottom there, right here. So 6 million people in the US have brain aneurysms. that what we call are not ruptured. So the kind of brain aneurysms that are there, but they haven't actually busted. They haven't ruptured yet. When it bursts, 40% of people will die, just like from the intracerebral hemorrhage, and 66% of survivors will live with some sort of a disability. So just like the other type of stroke, very similar numbers, very high rate of disability, very high rate of death from a rupture of an aneurysm. They most commonly develop post age 40, most commonly seen between the ages of 35 and 60. Women have aneurysm much more frequently than men, about 3 to 2 representation. Hispanics and African Americans are twice as likely to have an aneurysm, to die from an aneurysm, and to have a ruptured aneurysm. 500,000 deaths worldwide are attributed to aneurysm rupture. Risk factors. Here we go. Once again, hypertension. It's very similar than it is for ischemic strokes and intracerebral hemorrhage. Hypertension, smoking, heavy alcohol use, family history, so genetics is something you can't avoid. Obviously, female gender, age over 40. There are some genetic factors. So I don't know if you've heard of genetic diseases like Marfan syndrome, Ehlers-Danlos syndrome. So there are some genetic disorders that predispose you to having aneurysms. Drugs like cocaine and amphetamines. Tumors, so there are some tumors that can cause bleeding in the brain, and we discussed that already, and the trauma that I mentioned. But by far, once again, it's things you can control. 80% of strokes are preventable. How do we treat it? So main goal of treatment, medically, we lower the blood pressure and we keep people in the ICU to prevent something called spasm. Sometimes those arteries get really, really angry after an aneurysm ruptures. So they spasm, and on top of having blood in the brain, you can actually have an ischemic stroke when that artery collapses down. So we monitor blood pressure, we keep people well hydrated, we keep them in the ICU. Sometimes they need to be on a breathing machine to help them with the pressure in the brain. Surgical treatments, we have 2 types. One is when we open up the skull and we put a little clip on the aneurysm, and you can see that represented on the top there. We put a little clip, and at the neck of the aneurysm, we just cut off the blood supply so it no longer exists. Another surgical technique is that we put these little coils, you could see that on the right picture there, and these little coils are like the size of a little hair, and you just keep putting more and more and more coils until you fully occlude the aneurysm. It's like a ball of yarn. It just completely fully occluded, and it is no longer functional. The benefit of coiling an aneurysm, it is less invasive. They can go through the arm or through the groin with a catheter and do it internally versus the clip where you have to open up the brain and put the clip on. And this is somebody that has what I mentioned before, arteriovenous malformations. This is like this little kind of ball of, I think this is probably better. There's like a ball of blood vessels, and you can treat that with glue or coiling in some sorts. And then this picture here shows you like a representation of the whole entire ball of abnormal blood vessels are gone. So the surgical techniques are so advanced now that we're able to internally treat aneurysms and all of these vascular anomalies. So before we end the stroke portion today, is someone on the planet has a stroke every 2 seconds. So calculate how many seconds have evolved since we've all been together, right? This is how many people on the planet have had a stroke. So it is a very, very common, unfortunate disease. 1 in 4 people worldwide will have a stroke. 1 in 4, that's a lot. But guess what? 80% of strokes are preventable. How are they preventable? Because we're going to practice prevention, right? We're all going to practice prevention. And this is our gator. And you have to remember the signs of stroke. I think Dr. Kincaid kind of went over it many, many times with you. So remember fast, remember the signs of stroke. And with that, I will end. Thank you.